It is my pleasure to welcome our presenters, Drs. David Turok and Andrew Garrison. Dr. Turok directs the Family Planning Division at the University of Utah and is the Director of Surgical Services at Planned Parenthood Association of Utah. He worked for the Community Health Centers Incorporated in Salt Lake City for 15 years, where he was a part-time vasectomy provider before becoming nearly fully devoted to clinical research. And Dr. Turok is joined by Dr. Garrison, and he's a family medicine physician who is also medical director and a vasectomy provider at Community Health Centers Incorporated. So we are among experts today. Dave and Andy, take it away.
Caitlin, thank you so much. Okay. This is quite a pleasure. Andy, I don't get to see Andy nearly enough, though. I am so old now that nobody remembers when I was an intern, but I remember when he was. And it is an absolute pleasure to be sharing this conversation with him. Andy is a phenomenal physician, and I think as an intern, he was one of those people where you would just show him something once and he would have mastery for life. So his outstanding clinical skills will be what we will be leveraging today, especially in the second half of the talk. I'm going to talk a little bit about some background material first.
And Dave, speaking of sharing communication and conversation, we would love to have you share your screen, which is not showing up for us yet.
Oh, really? Huh.
The anticipation is building.
Okay, now better?
Wait for it. Oh, here we go. All right.
Perfect.
Thank you for the prompt. I thought I had it. I thought I was so slick there. All right, moving on. So we are unfortunately, the purpose and ability of this session is not to make you empower you to be a vasectomy provider for life. However, it is to review some basics of vasectomy service implementation and understand the no scalpel vasectomy technique, which is what people should be using, and we'll discuss why, and then discuss the management of uncomplicated vasectomies. And this is very much something that can be accomplished in the settings where you all work. So why is this important? You know, there are several areas in comparison for permanent contraception where we lack data. And there's really no well done population level data, or even smaller, comparing people pursuing vasectomy versus some form of tubal occlusion or removal. And looking specifically at probabilities of pregnancy and complication rates. However, in the aggregate, for the information that we do have available, it appears that vasectomy is cheaper, safer, faster, stronger. And the reasons for that really are tied to the fact that in order to do a vasectomy, you do not need to get into the peritoneal cavity. And to do all of the available tubal occlusion or removal procedures now, you do. And even if complications are rare, you know, if the complication rates are very low, when anything gets done to 100,000 people or 1 million people over years by a whole bunch of, you know, variety of providers, things will happen. And things that can happen in the scrotum and be contained are much less potential consequence than things that can happen and go wrong in the abdominal cavity. There's no aorta or inferior vena cava in the scrotum. So it appears in that aggregate of data that we could compare, which is not perfect, that vasectomy actually is more effective. So the pregnancy rate is low. And as I'd mentioned, tubal ligation and tubal occlusion and removal procedures are more likely than in vasectomy. It's a lot cheaper. You don't need general anesthesia to have a vasectomy. And tubal procedures are, considerably more expensive. And this figure here is super low for a tubal ligation. Because it includes the operative costs, the hospital costs, and the physician charges, which are far in excess of this. In our community, it is not uncommon for, there's some providers that have self-pay prices for vasectomy for $500. There are also ones that have more, and there are sliding scales and family planning elevated providers where this goes to $0. All in all, estimated annual savings for vasectomy over tubal procedures are enormous. Despite this, there is a relatively higher use of female permanent contraception procedures, and the balance is, is 2 to 3 to 1. So it's much more common that people, of all the permanent contraception procedures, the vast majority of them are performed on people who have fallopian tubes. Which means, and especially since Black and Latinx women are more likely to use these, it means women from diverse communities are exposed to greater health risks and higher costs of care. And we use the term permanent contraception rather than sterilization as an evolution of language in a country where the negative connotations of sterilization and forced sterilization have been an unfortunate legacy, and permanent contraception, I think, provides a opportunity to first inform people that this is permanent and not reversible, and this is what you're committing to, and empower people, to have agency and range over their choices. So why are female procedures more common? It's potential for provider influence and market and insurance factors. And if you're on this call, maybe less likely, but there are, if you are, let's just think an private OBGYN, you, in your most well-intentioned place, maybe could say, I want to continue and provide care and have continuity of care for my patient, and would recommend, and this is a procedure I know, and I know I can do it safely, and might recommend the tubal ligation, and not as effectively support or advocate for vasectomy despite its obvious strengths, especially because you might also need to refer out and not receive the reimbursement for that procedure, in a less optimistic view of that. And patient preferences certainly guide this. There are several situations where vasectomy really is not an option, where people are absolutely done with childbearing and do not have a regular partner, people who are having a cesarean delivery and you're going to be right there, or have more than one partner. Those are cases where tubal procedure makes more sense. And then this slide shows disparities in vasectomy use that are race and income based. So on the looker's left, you see white, Latinx, and the use of these procedures in Black populations, and and then you can see how that variation increases quite dramatically as you move to the right here. And then in this, it's a disparity by income, and people who have higher incomes, greater than 300% of the federal poverty level, there's almost equivalency and actually greater use of vasectomy. And in lower income populations, less than 150% of the federal poverty level, there's a dramatic preference for tubal sterilization, for tubal ligation and tubal procedures. So let's talk a little bit about procedural issues based on that background. But that really frames this as an equity issue in making this something that is available in communities and to people with less financial resources. So if you have a patient who is interested in permanent contraception and you've counseled them on the options and they're selecting vasectomy, the way that we've done it, we had done it previously at the community health centers and at Planned Parenthood in Utah as well, is there was a pre-procedure visit where we went over the procedure and the risks and the failure rate. An exam was performed to assure that there was normal anatomy and palpable vas deferens bilaterally. There wasn't a hernia, which would create a more complicated surgical situation. People would sign a consent form before they got medications, if they were going to get pre-procedure medications, and review pre and post-op instructions. And then this billing is coded as contraceptive counseling, and that's reimbursement for this visit. And then discussion of an offering of medications. So, there are women do things that are much more painful than this with fewer medications. And if it's going to make it more comfortable for somebody, the procedure does take longer than, let's say, for example, IUD insertion or endometrial biopsy, but the local anesthetic is quite effective. And these medications are not required. And this is one of the few medical procedures I can speak from experience on the patient end in counseling. And I did not receive these medicines and never thought like, wow, I really could have used that. So Ativan or lorazepam, 1 milligram, I personally prefer this over diazepam or Valium just because shorter half-life and less likely to have a very long hangover. And for people who want a medication to help them relax for the procedure, I prescribe them 2, and I tell them take 1, 15 or 20 minutes before. And if you're still not feeling relaxed enough at that point, you can take a second one. And then hydrocodone, again, for people who feel like they may need post-operative pain control, you can offer 5 milligram prescription. This is from an old slide, and I would not prescribe 10 at this point. I would probably use 5. Andy, I don't know what your current practice is on this issue.
Right. It's a great point, David. And I think many of us go case by case. And for the majority of folks, some ibuprofen and Tylenol seems to suffice. And you'd maybe offer a 2 to 5 of hydrocodone for something that was maybe a bit more of a complicated case or somebody who was particularly anxious. But I think you're right on, probably less is more.
And I think the most important thing that is not on this slide is the use of ice post-procedure. And if you have somebody who's thirsty or likes beer in a can, that is a particularly simple and effective mode for sitting on the couch post-procedure. So I think one thing that's important to review with people is just the anatomy and explain what's going on, and that the incision and essentially interference with communication in the vas deferens is nowhere near and does not interfere at all with sexual performance and erection and stimulation. And this is a diagram that can show this. Basically, you're showing testes will still produce sperm and hormones. What you're doing is essentially interfering with this connection here of the vas deferens, and we'll explain more about that. But erection and ejaculation continue. Production of seminal fluids is the same, and the proportion of ejaculate that comes from the actual sperm is about 5%. So it's not very much. And then this is a close-up of essentially the scrotal skin and the many layers down to the vas deferens. And getting through all of these quickly and efficiently is the main advantage of the no scalpel vasectomy technique, which we'll talk about in a bit. And then discussing informed consent and the potential risks of bleeding and potential hematoma, but the vast majority of times this is nearly bloodless. Risk of infection is also very low. Pain and a post-procedural pain, swelling, sperm granuloma, these are all possible and in the realm of 1%. And as is pregnancy, less than 1%. And regret. This is, you are committing to something that is permanent and essentially not reversible unless heroic actions are undertaken. So it is theoretically possible, and there are certainly will always be demand for vasectomy and tubal reversal. But I think it's worth screening people at the beginning to assure their commitment so that you minimize the number of people who are going to need to pursue that care that is likely to be out-of-pocket expense and very costly. So precautions, and I think this is important if you're going to be participating in referring people and counseling people on their options, to assure that there's not active local or systemic infection, including skin infections such as folliculitis or fungal infection, prior scrotal injury that may distort anatomy, coagulation disorders, though there are certainly people who will do the procedure in that case, diabetes, which may affect healing, or inability to palpate and elevate the vas deferens on both sides. And if you're not sure, certainly referring somebody for evaluation, or let them know, like, I'm referring you for the procedure. However, if the doc who's the person who's going to do this is not able to feel your vas on both sides, this might not be able to be done. And then assuring people that they are screening for a lack of desire for possible future reversal, and these other masses that can occur within the scrotum that make for greater complications and may need additional surgical procedures. And then people who may be co-opted or inadvertently or directly pursued or pushed into vasectomy, and understanding the situation where people present and being clear that this is not going to fix problems. It's super effective at preventing pregnancy, but it's not going to heal any of these other issues. And again, I've frequently repeat several times is permanent and non-reversible, and you are confident in the number of children you have and your current relationship situation. And I think one of the things that I've seen, there's a vasectomy listserv that is quite active, and it is very a common and recurring discussion is, do you do vasectomies for people who have not had children, especially young people? And my personal feeling on this is if an adult understands what I've said about this being a permanent and non-reversible procedure and is willing to commit to that and understands and desires not to have children, that is a perfectly good and reasonable choice. And as long as that is understood in both directions, I am absolutely fine with that. We all do things that we live with the consequences of, and if that is somebody's desire and they are committed to it, then they certainly have the right to receive that care. It is worthwhile knowing the current method of contraception, as this is not immediately effective, and that is the one downside of vasectomy, that you need to wait a bit, and people need to return and have a semen analysis to confirm that it's in fact effective and that there are no motile sperm left. And I think people vary on how much they push people on to consider if their life situation were to change. Would you want to be able to reproduce in that situation? But certainly a topic worthy of consideration. And then this is just basic historical issues and avoiding potential complications down the road. In the exam, we've talked about several times. I just want to talk a little bit about no scalpel vasectomy and introduce that before Andy takes over here. Were you going to start here, Andy? Or should I go a couple more?
You're welcome to make a couple more slides there, Dave. So yeah, go ahead.
Yeah, I think this is the last. So this was a procedure that was started in the Sichuan province in China in 1974 by Dr. Li. And there was a team at Engender Health who pursued this and shared. And actually, Andy, I'm going to pass to you now, if that's okay.
Yeah, sounds good. So, thank you, Dave, for that great background. And we'll kind of dive now kind of more into discussion about what is the no scalpel vasectomy technique and why that offers benefits, and then sort of, again, kind of what we can expect as far as counseling and sort of patients' experience in the procedure. So a little bit of sort of, in my mind, kind of fascinating sort of history of medicine here. So for whatever reason, there's been a somewhat long-standing way of celebrating the King of Thailand's birthday by having a vasectomy festival. I don't totally know the connection there, but apparently the King of Thailand has historically been somewhat of an advocate of reproductive health, and I guess there you have it. So sort of the seminal paper, no pun intended, around sort of no scalpel vasectomy, comparing that to incisional methods, was done at one of these King of Thailand's birthday vasectomy festival, where they had essentially, I think, a fairly small number of vasectomy providers just doing a really strikingly large number of vasectomies in a single day. This was not a randomized trial, but it really demonstrated that compared to the traditional incisional VAS technique, your risks of infection, hematoma, and complication rate was really quite a bit lower than no scalpel technique. The other takeaway from this is that apparently there was sort of in Thailand some thought that perhaps vasectomy would be correlated with erectile dysfunction. So they really try to counteract that by the slogan, "My bird flies high, it's been vasectomized." So that seemed to sort of be kind of a way to get people in the door. So I kind of like that as well. So it's sort of a good counseling point. Take the next slide there, Dave. Yeah, so again, this comes from a Cochrane review in 2014, and again, the largest trial in this was the King's birthday, but there's been a few more since then, showing essentially for any outcome that matters to a patient. So am I going to be bleeding? Will I have a hematoma? Is it going to hurt? And will I have an infection? The likelihood of those things happening with a no scalpel technique are significantly less than an incisional or scalpel technique. So it's clearly evidence-based. So take a pause here to be in a happy place. This is skiing in British Columbia. And the connection with vasectomies, I think for a lot of men, the idea of having a vasectomy is decidedly not a happy place. So we'll talk about sort of some techniques in terms of counseling and anesthesia to sort of make the experience maybe not quite as horrible as somebody might imagine. And kind of counseling point that I'll commonly say to folks that I think for many men, the idea of the vasectomy is perhaps a lot worse than the reality of it. And it's not uncommon for patients to leave asking either like, are you already done, or comment that was not as bad as they imagined it to be. So it's not a guarantee, but that's, I think, probably the more common experience.
I thought you were going to say vasectomy creates the opportunity for greater diversion time and more skiing.
That too. That's probably a good evidence-based point to make as well. No, for sure. Yeah. Maybe not the day after you get that done, but that's a good connection there. So kind of reminders for some preoperative instructions we give folks. So again, Dave kind of touched on the offering of lorazepam. I describe that as, you feel like you probably have a couple of cocktails or a couple of beers, you won't be unconscious, but you may sort of feel like that takes the edge off. We encourage folks to have somebody else drive them to and from clinic. In part, that's the lorazepam. It's in part because it's a bit hard to drive when you've got an ice pack in your underwear when you leave clinic. And then we also ask people to wear sort of an athletic supporter or tight supportive underwear to kind of hold the dressing and ice pack in place. Ask people to avoid aspirin and of course anticoagulants for a week prior. And then we can't emphasize enough that vasectomy is not immediately effective. So there has to be some form of other contraception between the time of the procedure and when the post-VAS semen analysis is done. So certainly perfectly fine to be sexually active, but we'd ask for or remind people that you really need another method during that time or your partner needs one. Thanks. So next slide. And then a couple things that can make the procedure perhaps kind of smoothest for all involved. So certainly bringing your phone and some earbuds to listen to music is great. We make a point of really trying to have all the solutions that'll touch the scrotum warmed up. So as George Costanza says, shrinkage is a thing. The cremasteric reflex can make vasectomy really much more challenging. So it's trying to have both the patient and also the cremasteric muscles as relaxed as possible and make everybody's life a little bit easier. And then in terms of preparation, if the anatomy dictates, we'll do kind of a little kind of clip of the front of the scrotum to remove hair, so that's not getting in the operative field. And then also if sort of need exists, we can kind of fasten the penis kind of up and out of the operative field to kind of fasten onto somebody's, the bottom of their shirt. That's kind of the preparatory steps we take. And then next slide there.
Do you still do that?
I rarely do. I think for the most part, just sort of the back of the hand kind of keeps the male anatomy out of the way. So rarely, is that necessary? The way that I was taught about this is sort of this contraption involves a rubber band with a safety pin attached. And it seemed like when men saw a safety pin coming at their penis, that was a source of anxiety that probably didn't, necessarily get us too far. So I rarely do anymore.
Yeah, I
but it's
think
certainly
you're
an
right,
option.
right on the money. I was trained to do that and did it way too many times before somebody pointed out that you don't have to do that.
Right. No,
Might have been you.
I agree. Right. So we'll kind of dive into sort of what the procedure sort of looks like. And again, the intent is not so much that you would sort of finish this session being able to perform this independently, but certainly have a handle on how to counsel patients as far as what to expect and maybe have a basis for pursuing training on your own perhaps. So this is a slide showing just the setup of the instruments that we use. So as you can see, it's a pretty sort of limited set. It's certainly way, way less involved than instruments you would need for a tubal ligation, right? And then for those that are not aware, the sort of item in the upper left-hand corner is just a little handheld fine tip cautery that we use to sort of cauterize or seal the vas closed. And I'll talk about the other instruments on the next slide here. So these are the secret weapons. So if vasectomy was time travel, these are like the flux capacitors of vasectomy. So they sort of what make the whole thing possible. So, and these are kind of two instruments that I think were actually developed by Dr. Lee, and really, as far as I know, are really kind of used just for no scalpel vasectomy. So on the left is what we would call a ringed clamp or a vas clamp. And as you'll see in a second, the purpose of that is to allow you to grasp the vas through the skin, which is sort of the key to the whole no scalpel technique. And then on the right is a dissecting forceps, which, as the name implies, allows you to both pierce the skin and sort of pierce part of the vas and do some dissection, but also without sort of having the sort of necessarily kind of cutting that a scissor or a scalpel would. So it's kind of both a grasping and a piercing or dissecting tool. So they're both really slick and make the whole thing possible. So, anesthesia. So again, for the majority of men, the local anesthetic is by far the most painful part. And the counseling I'll give is that it feels like an angry bee coming at your scrotum. And once you've been stung, then you're fine after that. And most men are pretty understanding of that. So the idea is we do a vasal block, and actually there's the vasal nerve kind of comes down from the inguinal canal along the vas, and by putting a nerve block around that, you then kind of get anesthesia for the procedure. So it winds up being a little skin wheel kind of right where you're going to pierce the skin, and also this vasal block that kind of goes up more proximal. And again, most men are pretty surprised that once that goes in there, you can open their scrotum and dissect out the vas, and they don't really seem to notice. So it's pretty slick. And take the next slide there. So this just kind of shows the process of what the anesthetic injection looks like. So we begin by bringing the vas up to the skin, and that uses a technique that I'll demonstrate or show more in a second. And we inject a little wheel of skin in the midline of the scrotum over the median raphe, about halfway between the testicle and the base of the penis. And that little skin wheel is where we're going to open the scrotum. And then on the next slide, I'll show you how we advance the needle kind of up along the vas towards the inguinal canal, and inject somewhere between 2 and 3 to maybe 5 cc's of 1% lidocaine. And then you repeat on the other side. So you can typically use the same skin wheel to get it both basal size to block it. So really it's just kind of that initial skin wheel that really kind of hurts. And men will occasionally kind of jump and try and grab your hand, and then after the anesthetic kicks in, they're really pretty good from there. Okay, this is kind of the key to the whole procedure. Is it is possible to really kind of using this 3-finger hold to manipulate and grasp the vas from sort of the posterior or kind of lateral area of the scrotum, where the vas typically will live, up to just below the skin. So the procedure kind of begins by the operator's grasp, once the block is in, by grasping that vas and bringing it up to the skin. And then on the next slide, I'll show you what that looks like. I think here there's kind of a little hint of sort of a white sort of structure between the 2 fingers there. I'm not sure that typically one can really see the vas through the skin. More it's just sort of something one palpates. But again, the idea is sort of you grasp that vas midway between the testicle and the base of the penis and bring it right to the skin, and sort of slide that sort of vas medial, so it's sitting right under the area where your skin wheel was. And then
That is pretty amazing, though, no?
Yeah, it is. It's sort of an amazing sort of that the anatomy works to make this possible. Yeah.
I meant the picture that they could actually, you can see anything.
see the vas. Yeah. And then so once we've got that vas grasp and brought up to the scrotal skin, then we use that special ringed vas clamp to just basically pinch the vas through the skin. So within that sort of grasping motion, you have both the vas and also sort of the various layers of fascia and skin that cover it. And the kind of the ideal here is that kind of the more you can spread the skin before you grasp the vas, so the less there is between the skin and the vas, the easier the dissection is going to be. And I'll show that on the next slide here. And then, so once you have gotten that vas grasp kind of perpendicular to the skin, then you kind of lower that clamp down so it's kind of more parallel to the skin. And in doing that, you kind of, the vas itself gets elevated. So you've got this sort of loop of vas that's kind of right under the skin. And typically at this point, you can actually give a little tug on the ring clamp, and that will just kind of make sure that the testicle that you think the vas is connected to, it actually is connected to. So there's probably case reports of people sort of, having a vasectomy failure because the operator sort of cut the same vas twice and didn't get the other side. So we just try and check and see, make sure by a little tug that you've got the testicle you think you are attached to. So you kind of palpate and make sure you've got the vas as well. Because sometimes if people have kind of thicker skin, it'd be hard to be certain that you've really got the vas without sort of that little palpation and making sure you can still feel the vas superior to where your clamp is sitting. And then you get out your dissecting forceps, and this is where you open the skin, again, not using a scalpel or incision. So you essentially just use one blade of the dissecting forceps to pierce the scrotum at a 45-degree angle, kind of parallel to how the curve of the vas is superior to the clamp. So that's how we open the skin. So it's just a quick little puncture that might only be 1 millimeter or 2 wide. So it's a pretty slick skin opening. And then once you've got that opening, you can use then the blunt dissection sort of feature of the dissecting forceps to just spread that skin opening to a couple 3 millimeters. And typically at this point, once you dissect, then you'll have a really clear view of the vas sort of right there in front of you. This part, I guess in my experience, took me kind of a while to kind of figure out how much piercing a dissection was enough. I think you do not enough and you've got a bunch of skin to go through. You do too much and you've transected your vas and you sort of created a world of trouble for yourself. So this is maybe sort of one of the learning points of sort of how much is enough. And that's sort of just kind of a feel and kind of time thing, I think. And then on the next slide here. So once we've got kind of that little skin opening, then we almost use this, the dissecting forceps almost as like a skewer. So we actually kind of turn it or begin to turn it in a rotation sort of fashion with our hand and actually kind of use that lateral blade to kind of partially pierce the vas. And then on the next slide, I'll show you what happens next. So once we've got that vas sort of skewered, and again, the idea is sort of just gently kind of skewered, not totally transected, not trying to cut it, just trying to get a hold of it. Then you rotate your dominant hand. And this is kind of the crux of the whole thing, because as we're kind of rotating, we're also opening that clamp kind of simultaneously. And that's sort of, again, a little bit of a timing thing, where if you release the clamp too soon, the vas drops back on the scrotum and you're kind of back to square one. And if you don't let it go, you can't, of course, raise the vas out of there. So it's kind of a, trying to walk and chew gum at the same time sort of thing. So not hard, just takes a little bit of practice to get the hang of. And then kind of once we get the vas out of the scrotum, you'll recall that the vas is kind of covered with a couple of layers of fascia and kind of running in there as a vasal artery and some veins. We really want to be able to kind of dissect the vas free from that fascia and the vasal artery. So we then use our vas clamp or the small ring forceps to grasp a partial thickness of the vas. So not the whole thing, just kind of partial thickness of it. And then the next step, the next slide here, we actually then use the dissecting forceps to actually puncture the vas sheath right below the vas. And, in the picture, those arteries look pretty innocuous. In real life, sometimes they can look really sort of more threatening, because again, you sort of, inadvertently puncture one of the, the vas artery. That sort of becomes a little bit of a deal to kind of get a handle on that. So you really try and aim for a spot where there's not sort of a likelihood of puncturing the vas artery. And it's not the end of the world, just sort of takes a bit more time to kind of get sort of a handle on a little bit of bleeding. So we try and puncture that sheath in an area where there's not an artery or a little vessel right there. And then after that, then you can introduce both tips of the forceps and then simply spread. And that kind of hopefully kind of dissects the sheath and the artery down, leaving you with just this, just the vas itself and nothing else. And again, occasionally you have to kind of, either cauterize or tie off some bleeding, which if you get into that, and again, it sort of doesn't happen rarely. And then so you're left with sort of, again, this sort of vas that's really nicely isolated, and the sheath and the vessels are separate from it. So that's kind of the idealized view of what you have at that point in time. Yeah. And then you've got a whole menu of things you can do with the vas. So, I think there's a lot in medicine where, people sort of agree about the one best way, and this is clearly not that situation. So you can cauterize, you can excise, you can ligate, you can do various combinations thereof. And the challenge here is that, there's a lot of data around these techniques, but there's less than one would like in terms of true head-to-head comparison. So where I think a lot of practitioners have landed is going by the American Urologic Association has a fairly evidence-based guideline on vasectomy, and they kind of lay out what they consider to be sort of acceptable ways of managing or occluding the vas, and several are illustrated here. So it's certainly possible to simply excise, so cut out a loop of vas, and then also at the same time use your fine tip cautery to cauterize, or I think it is sort of scarring close the either one or both vasal ends. It's also certainly possible to do some combination of cutting or dividing the vas and then actually sewing with a couple simple interrupted sutures a loop of the vas fascia to actually interpose and sort of create a layer of fascia between the vasal ends. And I think the idea is then you've sort of created a layer of tissue between the ends of the vas. So even if, perhaps one end of the vas was not totally occluded by your cautery, there would still be kind of a, sort of like a belt and suspenders approach there. And again, some providers will actually kind of ligate a free end of the vas and then do a fascial interposition. And then actually, perhaps the most efficient method is simply to do several centimeters of intraluminal cautery and not even excise any piece of the vas. So in these studies of any of these techniques, the best available data would have a less than 1% failure rate for any of these. The numbers sort of mentioned here are from kind of an older review article that I think probably doesn't include some of the more recent data. But again, the AUA would consider any of these to be acceptable and kind of preferable first line options. So it really is kind of provider preference. I think for me, I sort of like being able to tell a patient that we're actually cutting a piece of the vas out. That I think kind of is heard as being kind of a satisfying and sort of definitive thing. Is there evidence saying that's any better than the extended cautery? Perhaps not. In general, there is probably a little bit of suggestion that doing some form of fascial interposition is perhaps better than not doing that. But again, the failure rates are acceptably low, even if you don't do a fascial interposition. So I typically don't, simply because it's sort of, I think, again, we get to a less than 1% failure rate without doing fascial interposition, which I think is acceptable for most patients. And then on the next slide is a couple of techniques that are less recommended. So the AUA guideline sort of has this sort of qualified recommendation saying that if providers in their own experience seem to have acceptable failure rates using techniques, they're okay to use that. I'm kind of reminded of a colleague who said, I had this buddy who mostly did medicine by anecdote, and it mostly went okay for him. So it's, I think it's kind of a way of saying there's probably less robust data for the ligation techniques. And I think the thought is really that when we ligate the vas, the sort of end distal to that ligation may become necrotic and slough off, leaving sort of a viable vas end kind of floating in space that might then recanalize. So even though the idea is that maybe, ligating it might work, the reality is perhaps kind of the ligation might actually be kind of productive. So probably not kind of first line here. Okay. And then really kind of key points for afterwards. So as Dave mentioned, ice is a fantastic analgesic, prevents inflammation, prevents swelling. So people walk out of clinic with an ice pack. And I should just kind of batch up to two last points. So we obviously repeat the procedure on the contralateral side. So you do the same on the other side. And then there's typically not a need to close the skin. The opening is, 2 millimeters, 3 millimeters. So typically that's not even really easily visible in the skin folds. I'll occasionally put a simple interrupted suture in there. like one subcuticular stitch if I had to sort of have a bit more of a than typical size opening, or if there was some bleeding from the skin edge, but not typically requiring closure. And then we'll apply just kind of an ice pack on the scrotum and then let the patient's underwear support that ice pack. So they kind of walk out doing this sort of little bit of a kind of waddle because they've got this ice pack in their scrotum, and then kind of sit in their car. And we tell patients to plan on doing basically nothing besides sitting on the couch and watching a movie or soccer or whatever for 24 hours afterwards, again, with an ice pack on for the first afternoon, and then find a shower and bathe the day after the procedure. For me, Fridays are typically a pretty busy vasectomy day, and the counseling is typically by Monday, you're fine to go back to work for most people, with the caveat of trying to avoid sex and kind of strenuous activities like a really intense workout, that sort of thing, for 7 days afterwards. And again, the vast majority of men are, feeling perhaps a little bit sore the next day, but then are kind of, basically kind of good to go by 2-3 days afterwards. And then again, key reminder is that the vasectomy is not immediately effective. You got to come back for that post-vas semen analysis, which we'll talk about right now. So get the next slide here. And then I'll mention too, so, complications are real. The sort of numbers cited by the King's Birthday VAS Festival, kind of small number of providers, maybe somewhat of sort of idealized circumstance. The real world numbers are probably more like kind of 1 to 2% for hematoma, which usually doesn't require intervention surgically, but could just kind of be pretty painful to have kind of a, walnut or maybe even kind of tennis ball sized hematoma in your scrotum for a month. It can take a while to resolve. So that, it doesn't happen commonly, but it happens at an appreciable rate. And then somewhere around 1% of men will have months or even years of pain after vasectomy. And I'm not sure that physiology is really understood. There may be sort of some thought of a sort of congestive epididymitis if the vas was occluded, or maybe kind of a sperm granuloma if it's left open could be causing pain. So there's no real clear data saying one technique or another leads to more or less pain afterwards, but some, again, a very small number of men will have kind of medium to long-term pain afterwards, which typically can be managed, but it certainly is a risk worth mentioning. So what do you do afterwards? So the short answer is that the vast majority of men, so 80%, when they come back for their first semen analysis 2 to 3 months after their VAS was done, will have aziospermia. So basically kind of a sperm count with no modal sperm seen. We don't really kind of put a specific number of ejaculations, typically just say sort of come back in 2 or 3 months and give us a semen sample. And then, a small number, we'll talk about this more in a second, we'll kind of persistently demonstrate non-modal, or you think of them as sort of dead sperm. We'll talk about sort of what to do in that case. What the AOA says is that patients can stop using other forms of contraception when a semen analysis shows either aziospermia, so a sperm count of 0, or rare non-modal sperm. So the basic counseling point is please don't rely on the vasectomy until you come back at 2 or 3 months for a semen analysis showing a sperm count of 0. And please do that, because otherwise we don't really have a guarantee of this having worked. So the next slide has a little kind of flow chart or algorithm here. So again, we have patients come back 2-3 months. If their semen analysis is negative at that point in time, which is 80% of men, you've got the green light to rely on that for birth control. And again, men are perfectly welcome to have sex during this time, just a matter of using a backup method if they don't desire a pregnancy. And then again, about 20% of patients will have a small number of non-modal sperm on that first semen analysis. So if there's a small number of non-modal sperm, we'll kind of walk down this kind of left-hand algorithm there and have them come back for another semen analysis in a month or 2. And typically kind of that second follow-up, sort of, 3, 4, 5 months down the road, will be negative at that point in time, at which point they've got the green light to rely on the vasectomy for birth control. You will very rarely see a man with persistently non-modal sperm, even kind of months to a year or so after the vasectomy. The data in that setting seems to suggest that the risk of pregnancy in that setting is about the same as the risk of pregnancy in a man with aziospermia. So certainly reasonable to kind of engage in shared decision-making and say that even though your sperm count isn't technically 0, the sperm you have there seem to be not going anywhere and the risk of pregnancy is quite low. in that setting, some men may elect to go with that. Some men may elect to have repeat the vasectomy, but it's certainly kind of a point of discussion. And then in the rare occasion where you have persistent numbers of modal sperm, kind of walking down the right side of the algorithm there. If you get to 6 months out and there's still appreciable numbers of modal viable sperm, that would indicate some kind of vasectomy failure where recanalization has occurred. And at a point, really kind of offering another vasectomy is kind of the way to go. So persistent modal sperm beyond 6 months would really indicate a failure. So counseling point is, again, don't be surprised if you're in the 20% of men who 3 months after the vasectomy still have a small number of modal sperm. But again, the vast majority of those will then dissipate over the next kind of couple of months. And by 6 months, the vast majority, north of 90+%, have aziospermia. Okay, next slide there. So yeah, to wrap up, as Dave kind of emphasized earlier, the counseling point is vasectomy is as effective, yet less costly and safer than tubal ligation or tubal contraception. There's really a significant race and income-based difference in vasectomy use. And I think, in this setting, it's really great to have a discussion around how can we make sure we're eliminating any possible barrier to vasectomy access for families and men that might want this. And then, as we've seen, the no scalpel vasectomy is office-based, quick procedure. The idea is worse than the reality. It's typically not a big deal for most men, has a very low complication rate. And then really key takeaway is, remember, that's not going to be effective right away. You really, please, for the love of God, come back for that 3-month post-vas semen analysis to make sure you can really rely on that. So yeah, I'll stop talking here, and we're happy to engage questions and comments and discussion. And thanks for your time on what I think is kind of a neat topic for lunchtime discussion. So thank you for your attention.
I have one if there are no other questions. I was intrigued, Andy, by the that 1.4% of patients who experience the persistent non-modal sperm. What's the mechanism? Like, what's happening there, right? Like, the sperm are somehow getting through the vas, but they're dead. Like, what's the experience from the sperm's perspective?
Yeah, so the thought is they actually may be coming from the seminal vesicle. There may be sort of a reservoir sort of in the seminal vesicle in the pelvis, and they're kind of, I think of it as kind of leaking out from there. So I'm not sure it's super well fleshed out, but that's, I think, felt to be the more likely source than somehow kind of getting through a recanalized vas. Because I think in the setting of where the vas recanalized, you'd actually probably see higher numbers of modal sperm, and the sort of kind of dead ones that leak out probably are coming from seminal vesicles.
Thanks.
It's also possible early on where there has not been enough flushing and some persistent sperm have hung out and not yet, they're not alive, they're not still swimming, but they are around. And, we didn't really talk about this, Andy, I don't know what your experience with this is, but I never recall seeing more than half the people actually come back. And that has not been evaluated as a successful technique, though I have seen early pregnancies from people who didn't wait.
Yeah, no, and I think our experience, Dave, is the same, that there's a significant minority of men who never come back, and that's certainly a disconcerting idea. There was a question in chat about anybody training NPs to do vasectomies in Utah, and that's a good question. Dave and I and Caitlin were sort of chatting, and I the one piece that I wish we had a great answer to is where you can then go to sort of get clinical training, and I'm not sure we have a great answer. I mean, I think even the family medicine residents, the university, those that want to do vasectomy training, even they have a difficult time getting the numbers they're looking for. So I wish I had an answer, and I'm not sure that I really do. I don't know if Dave or Caitlin have thoughts about sort of any potential training resources, but that's a good question.
Yeah, there's all the people that I ever trained were in part of a residency or training program, and There is a guy, Doug Stein, who's very devoted vasectomy provider, is a urologist in Florida, and he has a rather costly program where he will line up a large number of patients over a couple of days and do them with you as a training. But you need to have some foundation before you do that to actually get something out of it. And he is incredibly efficient. There are a bunch of people on that vasectomy listserv that I mentioned earlier, whose operative time is less than 5 minutes. And that is super impressive. But if you do, thousands of them a year, that's, to be expected. So I don't have a great answer for training. And I don't know of a great option right now, unfortunately. I will say this, and I guess, Andy, I thought at one point, like, this is the only clinical care that I'm going to do eventually. I will just completely commit to this because there's such a great need. And I was never able to get so efficient as to be able to do it in 5 minutes or anything close to that. And, we weren't able to generate enough demand and practice, but it is among minor office-based procedures. I do think it's the most challenging and the most difficult. I want it to be super easy and simple. And I think it's a little bit more than that. I don't know what you're feeling on that, Andy.
Yeah, one of our colleagues, Dave Gontrim, who's an experienced provider too, he and I were chatting, and he used the description as deceptively challenging, which I think it's a great. I mean, I think it's one of these things where the sort of the pictures when things go like that, it's easy, and again, to use Dave's words, the reality is more often it's a man with a scrotum the size of a walnut and skin as thick as an orange peel and testicles the size of marbles, and that's a technically challenging procedure. So no, it's sort of, it can be challenging.
Yeah, it is. The person I think who's talked the most about this and written the most about vasectomy in the modern era is this guy, Michel Lebrec in Quebec, and I think all of his patients are these very skinny French Canadian dudes. And so he never encounters what Andy just described with the walnut sized scrotum with skin as thick as an orange peel. That is exactly the challenge. And much more likely to be encountered, I think, at the community health centers in Salt Lake City than Quebec City. Sorry,
wonderful. Kate. Thank you both so much for this really informative presentation. Certainly my first exposure to what the vasectomy procedure is like, and I'm happy to have that information now.